Published today in the American Journal of Obstetrics and Gynecology is a study which shows that vaginal progesterone reduces the rate of preterm birth and neonatal complications in women with a singleton gestation and a mid-trimester sonographic short cervix. Preterm birth is the leading cause of perinatal morbidity and mortality worldwide, with 15 million babies born preterm annually. Premature babies have complications because of the immaturity of multiple organ systems. This baby has difficulty breathing because of respiratory distress syndrome, the most common complication of prematurity. Other complications affecting preterm neonates because of immaturity include intraventricular hemorrhage, necrotizing enterocolitis, neonatal sepsis, and retinopathy of prematurity. A short cervix, defined as a cervical length of 25 millimeters or less, is a risk factor for spontaneous preterm delivery. 25 millimeters corresponds to the 10th percentile for cervical length. Sonographic cervical length is used to assess the risk of preterm delivery in the mid-trimester. Thus, a short cervix is used for prediction. Progesterone is a natural key hormone for pregnancy maintenance, and a decline in progesterone action can induce cervical ripening, which includes cervical shortening. The study published today is an individual patient data meta-analysis, which includes all available randomized clinical trials comparing vaginal progesterone versus placebo for the prevention of preterm birth and/or adverse perinatal outcomes in women with singleton gestations. The primary objective of the study was to determine whether vaginal progesterone reduced the rate of preterm birth at less than 33 weeks in women with a singleton gestation and a short cervix. The investigators identified all available randomized clinical trials published up to September 30th, 2017. Secondary outcomes included preterm birth at different gestational ages and other neonatal outcomes that are listed on this slide. 5 trials, including 974 women allocated to vaginal progesterone or placebo, were included in this individual patient data meta-analysis. The effect of vaginal progesterone on the primary outcome is illustrated in this forest plot. There was a significant decrease in the rate of preterm birth less than 33 weeks by 38% for the primary outcome as illustrated by the blue diamond. Vaginal progesterone administration was associated with a reduction in the rate of preterm birth at less than 28, less than 30, less than 32, less than 34, less than 35, and less than 36 weeks. The reduction of preterm birth at less than 36 weeks had not been demonstrated previously. Vaginal progesterone administration was also associated with a reduction in the frequency of admission to the newborn intensive care unit, respiratory distress syndrome, composite neonatal morbidity and mortality, and birth weight less than 1,500 grams and less than 2,500 grams. Moreover, there was a clear trend towards reduction in neonatal death and the use of mechanical ventilation. In conclusion, women with a sonographic short cervix in the mid-trimester allocated to receive vaginal progesterone had a lower rate of preterm birth at less than 33 weeks and less than 28, less than 30, less than 32 weeks, less than 34, less than 35, and less than 36 weeks. For neonatal morbidity, babies born to mothers who receive vaginal progesterone had significantly lower rates of admission to the newborn intensive care unit by 32%, respiratory distress syndrome by 53%, composite neonatal morbidity and mortality by 41%, birth weight of less than 1,500 grams by 38%, and birth weight of less than 2,500 grams by 18%. Placing the results into context, there are 2 important questions. The first is universal assessment of cervical length with ultrasound and treatment with vaginal progesterone of patients with a short cervix cost effective? And second, does universal cervical length assessment coupled with vaginal progesterone reduce the rate of preterm birth? Several cost-effective analyses have been reported. All but one agree that universal screening of cervical length results in cost savings. For example, Warner et al. From Yale University estimated that universal cervical assessment and administration of vaginal progesterone could save the United States healthcare system $19 million for every 100,000 women screened if the cost of ultrasound is $184. This would result in a net savings of $500 million annually to the United States healthcare system. Results of implementation research studies have been published to examine whether real-world introduction of universal sonographic cervical length screening and vaginal progesterone can reduce the rate of preterm birth. The key conclusion of these studies is that the implementation of this policy is associated with a reduction in the rate of preterm birth in the real world. In conclusion, based on the results of the present study, the administration of vaginal progesterone to patients with a singleton gestation and a short cervix reduces the risk of preterm birth, improves perinatal outcome, reduces healthcare costs based on cost-effectiveness studies, and can be successfully implemented into clinical practice. More details can be found at ajog.org, where this paper is available for download free of charge, courtesy of the publisher of AJOG, Elsevier.